Thank you. Good afternoon. So my talk will be on how to assess the risk of AML evolution and the survival of patients with MDS. And this risk can be, this risk stratification could be made according to the disease itself, as I will show you later on, but it can be also assessed according to the patient and the comorbidities, and I will discuss that, of course, later on. And, of course, it should be assessed in a specific treatment setting, because all the scoring systems that I will present within the next slides were made in untreated patients. And whether those scoring systems are still valid in patients who receive a specific treatment remain sometimes uncertain. So there have been several scoring systems that have been developed so far, and they are based on very simple clinical parameters. And I will discuss with you the old classical IPSS scoring system that was published in 1987, but that is still valid. The Italian one, the WPSS, and more recently published revised IPSS. But there are many other scoring systems that have been published so far and that are all very effective to discriminate patients with different outcomes. So the first one was the International Prognostic Scoring System that was based on very simple data. First of all, the bone marrow blast that was divided in 4 categories. And you can see that this scoring system was designed before the WHO classification. So patients up to 30% of bone marrow blast were considered as having MDS. It was also based on the number of cytopenia, the presence or the absence of cytopenia, and on cytogenetics. There were 3 categories, including 7 subgroups. And those 7 subgroups does not reflect, in fact, the great cytogenetic heterogeneity that might be observed in MDS. Nevertheless, it was able to distinguish a different outcome for patients in terms of survival or AML evolution, with a very short overall survival, less than a year, for patients with high-risk MDS, compared to a very prolonged survival of more than 7 years for patients with low-risk MDS. And this was exactly the same for AML evolution. Another prognostic scoring system was published. This is the WPSS scoring system that was based not on the FAB classification, but on the WHO classification to discriminate the patient with according to the WHO classification. The cytogenetics was similar. The classification of the cytogenetics was rather similar than the IPSS scoring system, and it didn't take into account the number of cytopenia, but the transfusion requirement. And as you can see, once again, the scoring system was nicely able to distinguish different outcomes in terms of survival or leukemic evolution based on these parameters. And the scoring system was modified a few years ago by the same group, taking into account not the transfusion dependency, but the severity of the anemia, less than 8 or 9 grams, whether you are a male or a female patient. And once again, there was a very nice discrimination in terms of overall survival or AML evolution. As previously said, those scoring systems were based on cytogenetics that include only 7 groups of cytogenetics. And there was a very important paper published by Detlef Aase from Germany that distinguished in a large database the outcome of different cytogenetic abnormalities. I will not go into the details, but many cytogenetics abnormalities could be identified as of being of good or poor prognosis compared to the normal cytogenetics. And it was able to distinguish 17 different subgroups in terms of cytogenetics. Based on this paper, a new IPSS was published, so-called the revised IPSS, that take into account this new scoring system for cytogenetics, dividing the patient into 5 different categories, including 17 different subgroups for cytogenetics. The scoring system also takes into account a new definition, a new cutoff for the percentage of bone marrow blast count, highlighting the fact that having less than 2% or more than 2% of bone marrow blasts had not the same value. And it distinguished different outcome for patients with a high, medium, or low hemoglobin level, low or high neutrophil count, and low, high, or normal, let's say normal platelet count. And of course, the cytogenetics, as previously said. And altogether, those results were able to distinguish 5 different groups with different outcome in terms of median survival that could be very poor, with a median survival of less than a year for those patients, up to almost 10 years for patients in the very good group. There are also other prognostic factors that might that could be taken into account that are usually not included in the scoring system. This is, for example, the presence of bone marrow fibrosis in patients that might distinguish the different outcome in terms of overall survival or risk of EML evolution as depicted in this paper. The ferritin level is also of importance, even in patients with very low-risk MDS. And, Luca Malcovati published this study a few years ago showing that the serum ferritin level might have an impact even in very low-risk MDS in terms of overall survival and also in terms of risk of EML evolution. This paper highlighted the risk according to the disease, but what about the risk according to the patient itself and the comorbidities of the patient that might also have an impact in terms of survival? And this has been taken into account in different papers. This paper takes into account not only the disease, but also the comorbidities evaluated according to the SOROR score that is usually used in stem cell transplantation, highlighting the fact that in low-risk patients, according to the WPSS, having or not comorbidities might have an impact on overall survival. This was very clear in low-risk MDS, very low or intermediate risk MDS. On the contrary, in higher risk MDS, I mean in patients with high bone marrow blast count, the comorbidities had a very limited impact in terms of overall survival, suggesting that the disease is stronger than the patients and that the prognostic factors that might preclude the survival of the patient with low risk MDS had no impact in patients with a high risk disease. Other scoring systems evaluating the comorbidities have been evaluated. This is the ACE27 scoring system, and that has been evaluated in this paper. And once again, it was nicely shown that this scoring system might have an impact in terms of overall survival for patients with low, intermediate, or high, according to this scoring system. Do we have any biomarker that might also be effective to distinguish the outcome of the patient? And we have some. It was published in 2011 by Benjamin Ebert group that half of the patients with MDS might have some mutation in different genes. And now we know that up to 19% of the patient, when we include the new mutation that have been described since then, that 80% of the patient might have at least one mutation. And those mutations might have an impact in terms of overall survival, such as I6L1, RANKS1, TP53, AZH2, and ETV6 in this paper. And by multivariate analysis, this impact was independent of the IPSS risk group, suggesting that those mutations might add to the prognosis of those patients. I will skip this one. Do we have any information on risk stratification according to the treatment? Because all those scoring systems that have been presented so far were established in untreated patients. But is there any impact of, do we need a new scoring system for patients treated in the same way? For EML, the impact of NPN mutation the NPN mutation has no impact in untreated patients. It has an impact in patients treated with 3+7 chemotherapy. So maybe that we have to have new scoring system for patients who are treated with a specific drug. What do we know in high-risk MDS? We know that azacitidine might improve the survival of the patient compared to a conventional care regimen. And in the paper published in the Lancet Oncology, the survival advantage was observed in all the categories that have been analyzed, whether the patient had RAPE1, RAPE2, cytogenetics according to the IPSS being good or intermediate or poor, and so on. So all the patients had a survival advantage when treated with azacitidine. We took advantage of a patient name program that was designed in France, and we treated 282 patients with high-risk MDS with azacitidine, and those patients were all at higher risk MDS, I mean IPSS score being intermediate 2 or I. And we have identified that some factors might be associated with a response. And the response rate was lower when patients received low-dose Ara-C before azacitidine. The response were higher in patients with normal cytogenetics, and the response were lower in patients with high bone marrow blast count. We looked also at the factor that might influence the survival, and with a median follow-up of 26 months, we observed that poor performance status, high-risk cytogenetics, high transfusion burden, and the presence of circulating blast were associated with a poor survival. And those four parameters were combined into a scoring system. And this is the result of this scoring system, showing that in those patients with higher risk MDS, we were able to identify long-term survivor, patients with very good overall survival when treated with azacitidine, and patients who had a very poor survival, even in the setting of azacitidine, less than about 6 months for those patients, and it was not reached at the time of publication for this group. But the IPSS-R might be also useful to predict the survival after azacitidine treatment. And when using the IPSS-R stratification in those patients with higher risk MDS according to the IPSS, it is possible to identify different overall survival, whether the patient have intermediate, poor, or very poor IPSS scoring system score. What about cytogenetics? We did a large analysis of almost 1,000 patients treated with azacitidine in France, in Italy, and in several centers in the US to assess whether those patients treated with, to assess the role of cytogenetics among those patients treated with azacitidine. And we used the normal cytogenetics as a reference, and we observed that patients with isolated del(5q) had a better overall survival than patients with normal cytogenetics. On the contrary, we observed that presence of deletion 17p, non-isolated chromosome 5 or chromosome 7 abnormalities, monosomal cytogenetics or complex cytogenetics had a worse outcome than a patient with normal cytogenetics. So cytogenetics may play a role even in the setting of azacitidine. What about the role of mutation? It has been suggested in different papers that patients with TET2 mutation might have a better response to hypomethylating agents. And this is highlighted in this paper showing that the overall response rate in patients treated with azacitidine and in patients with TET2 mutation might have a significantly higher complete overall response rate than patients without this mutation. But despite this increase in the response rate, there was no survival advantage for a patient with TET2 mutation treated with azacitidine. TP53 might also play a role. I have highlighted the fact that TP53 in untreated patients is of poor prognosis, but in patients with high-risk MDS, the frequency of TP53 mutation is about 40%. And even in patients treated with hypomethylating agents, the outcome of patients with this kind of mutation, those patients might have a worse outcome, even when treated with azacitidine compared to wild-type patients. And if you take all the mutation together, and this has been done by the Cleveland group on a series of 80 patients that have been treated with hypomethylating agents, you can identify that patients with A6L1 might have a worse outcome than the other, and that patients with splice mutation SS3B1 might have a better survival than the others. I would like to say that this paper has been published 1 year ago, and in the French experience that will be presented in Washington at the MDS meeting, we found the exactly opposite, suggesting that in our hand, I6L1 mutated patient might have a survival advantage when treated with azacitidine. So we don't have a definitive answer on the role of this mutation in patients treated with azacitidine. So to conclude, there are several prognostic scoring systems that have been developed. They are based on very simple clinical parameters, and they are very reproducible and very easily manageable. The addition of new molecular marker might add some new information on the prognosis in untreated patients. It cannot be for the moment serve to determine the treatment that should be received by the patient because the work is still on progress. And we need larger cohort to confirm the role of this mutation. And I would like to conclude by saying that a prognostic tool should always be validated in patients with apparently similar disease and treated similarly. Thank you very much.